Namaste and greetings. I, Tanu Palewal, researcher at IMPRI, Impact and Policy Research Institute, Prabhav एवं नीति अनुसंधान संस्थान, नई Delhi, extend my warmest welcome to you all to IMPRI Web Policy Learning. Today marks the last day of Health Sector Management and Governance, an Indian Perspective, an online national summer school program, a 1 month immersive online certificate training course. This training program is organized by IMPRI, Center for the Study of Finance and Economics, CSFE, IMPRI Web Policy Learning. This program has an excellent panel of experts who will be sharing their expertise for the duration of this program. The expert panel includes Professor Mukul Asharji, Mr. V. Ramakrishnan ji, Dr. Parashram Patil ji, Dr. Manorama Bakshi ji, Ms. Urvashi Prasad ji, Professor Pradeep Panda ji, and Professor Sanghamitra S. Acharya ji. The panel of conveners comprises of Dr. Simi Mehta ji and Dr. Arjun Kumar ji. The chair of the program is Professor Mukul Asharji, former professor, Lee Kuan Yew School of Public Policy, National University of Singapore, visiting distinguished professor, IMPRI. Proceeding further, I welcome all the participants to this enlightening deliberation and thank you for being interested and putting your time, energy, and efforts into learning, sharing ideas, and contributing to the evolving landscape of healthcare management and governance. We have also shared the course outline and reading resources in your email. Before we start today's session, I would like to remind the housekeeping announcements once again. Please join the meeting on time. There will be question and answer session after each presentation. Share your questions on the question and answer box. The questions must not be posted as an anonymous attendee. Ensure that your questions are precise. Refrain from making general comments in the question to save time. Now, without any further delay, let us start with our program. It's my honor to invite Professor Sanghamitra S. Acharya ji, Professor, Center of Social Medicine and Community Health, Jawaharlal Nehru University, JNU, New Delhi, for the session on challenges in achieving better access, adequacy, and affordability of healthcare services within India. A very warm welcome to you, ma'am. Ma'am, you're on mute.
Thank you so much. Thank you so much, Tanu. Is this your alert for me to begin my talk?
Yes, ma'am.
Okay, thank you. First of all, I really want to put on record my deepest gratitude to the Institute, to IMPRI and the organizers for continuously putting their efforts to do such training programs, such webinars, such workshops, wherein there is a continuation of perhaps inculcating what is required to be in terms of preparing oneself academically and professionally in terms of learning about policy. So thank you very much for that. You've assigned the job to me is perhaps something which is fairly relevant in today's context. And as much as I understand the challenges in achieving better access, adequacy, and affordability in healthcare is something which we need to talk about. We need to talk about for reasons such as the way we've encountered health emergencies in the recent past, the way we have managed to respond to these emergencies in the near past and the past before. I think this is something which is very, very important to contextualize also in the light of the health systems which we boast of in terms of the country, in terms of ensuring that provisions of services vis-a-vis good health, vis-a-vis attainment of good health can happen. It's a vast theme. I'm sure you would agree with it. And therefore, perhaps I'm going to zero in perhaps not on all the challenges that perhaps we could be encountering. It's impossible. I'll zero in perhaps to talk about just two that I think are important to be talking about. I choose to speak on data how inclusive data becomes a challenge. And the second challenge that I wish to talk about is the realms of climate change, particularly the heat waves that we've encountered very recently. Just about May, that we've been reeling under 40 plus temperatures for more than a month. And therefore, I think these two, to my mind, to talk about today becomes important. Let's think about these two as I move ahead in terms of laying some kind of background. As we talk about access, perhaps, in terms of how do we improve access, what are therefore the what we say as adequacy, the suitability of the medication that could be provided versus what could be the affordability. I'm sure we'll agree when we talk of access, the context of access brings in the realm of right to be able to use whatever is being provided as a service, and health being the peg. Therefore, it directly connects with the idea of being something which enables there are safeguards which could be legal in nature, there are safeguards which could be socio-political in nature, by way of which there is access in terms of right to use that service which is there, which is slightly different from what perhaps we understand in terms of utilization. When we are contextualizing utilization, perhaps the realm is in terms of being able to make use of that service, avail for one's own self that service which is being provided, to be able to take the benefit of that service which is there. So to me, I think here is the context wherein we need to differentiate between access versus utilization. And that's where perhaps what becomes important is to think about the adequacy of healthcare services. This is where, to my mind, what becomes important is the connect with sustainability. Sustainability also in the realm of what we are today being geared towards, and geared towards the attainment of the goals which the SDGs have laid in front of us. So to me, I think I would want to propose that when we're talking about adequacy of healthcare services, it's very important to take note of the realms of, if I may say, over medication, for example, to being, therefore, if we're talking about over medication, what becomes the realm of perhaps medical malpractice too? In all of this, perhaps affordability of being able to access the resources becomes very, very important. And economic propensity, for that matter, becomes the element which will create that enabling environment wherein access can be made possible. Therefore, out-of-pocket expenditure, for one, becomes important to be seen in the light of, therefore, the existing inequalities which create those barriers for accessing health. And therefore, perhaps when I'm connecting the two challenges, to my mind, the environmental, social, and governance framework, which I think much of the literature is talking about as an ESG framework, becomes fairly relevant. I may not get into the deeper insights of the ESG, but I'm trying to draw from the concept of this framework vis-a-vis the two challenges I'm going to be kind of making the connect with. Now, when we are talking about inclusive data and we're talking about access, I think it becomes very important to take note of the realms of social inclusion of certain vulnerable populations that we have as part of the communities, as part of the total population in which we reside. So much of this vulnerability gets generated by way of the historical realms in which, if I may say, some communities have remained excluded. They've been excluded from the development, from the policies of the governments, by way of being able to access what the holds of policies enable them to do, or are directing them to be able to use. At the global level, therefore, to my mind, has been the realm of erstwhile Millennium Development Goals, which transform themselves as Sustainable Development Goals, if I may say so. That's the clarion call the SDGs give us, leaving no one behind. That's perhaps where this recognition that there are differences, groups which have remained excluded, groups which have been privileged, need to converge in some way vis-a-vis the access to resources. And therefore, I think the whole notion of sustainable development goals, with all its targets that it has placed for itself, United Nations does make itself very, very relevant in terms of giving a timeline, as perhaps the MGDs as well, to be able to focus on the people. The people-centric approach which SDGs promote in terms of principles of accountability, transparency, and participation that is ensured vis-a-vis, how the holistic development can be put in place. However, with all these positive signs, if I may say so, the paradigm shift, which kind of been seen in terms of the global development agenda, there are concerns as to how it reaches, how it impacts on the traditionally marginalized and socially excluded communities, not only within the country, but globally, to kind of connect it at the larger realms. And therefore, I think the next question which becomes important is, who are these excluded groups? Why do we need to therefore ensure the challenges of their access to various kinds of resources by way of making the data inclusive? We all, I'm sure, will agree that globally, across space and time, there have been population groups which have remained excluded: indigenous ethnic groups, tribal populations, minority communities, who are probably minority, attain minority status by way of language, by way of religion, by way of region, sexual orientation, in fact, sexual choices for that matter, or being differently abled, and caste, of course, in terms of South Asia, becomes very, very important realm to understand who are the excluded group. And I'm sure I don't need to get into the statistics of the excluded groups when we want to kind of come in terms of the South Asian scenario. Nevertheless, if we get into the documentation through data as well as literature, it's fairly evident that the population groups whom we identify as excluded groups are administratively labeled as the scheduled castes, the scheduled tribes, the backward classes. Based all of this perhaps emanates somewhere from their social identities, which are resting on the ethnicity, indigenous people, even amidst indigenous people, if we go by the variations of the tribes, the larger context of denotified tribes, for example, nomadic or semi-nomadic tribes, for instance, there is a lacune even in terms of enumeration when some of these specific tribal communities are concerned. Therefore, I think it becomes very, very important to be able to take on board what are these processes of enumeration, what are these processes of data collection of the excluded communities, which remain outside the fold of access to resources, particularly in this case that we are talking about the health resources. All the more it becomes important when we put the excluded communities together, even within the national fold and even at the levels which are global to a large extent. Roughly half of our population comes in the category of being excluded, if you go by putting together the SCs, the STs, the OBCs in that context. So the point therefore I'm making is, in terms of numbers, the quantum excluded groups are more, and therefore it's important to enumerate them, collect data on them in different ways, so that the policies which are formulated for ensuring the positive environments for them become relevant. Just to perhaps take on board an example in terms of how these policies which have been there in place across board have, while the policies have ensured, the affirmative action policies have ensured the upward trends in development indicators. Education, for example, if I take that, if we look at the literacy levels, for instance, across the social groups that we have administratively, they show upward trends when we are looking at the literacy rates from, let's say, the initial 1951 census to perhaps 2011. You take minority religions also, there are upward trends. But in these upward trends, that the gap that remain visible across the population groups which have had privileges versus the groups which have not had privileges, which have remained excluded, that's what becomes important in order to therefore look back at the processes of policy formulations which are based on the way data collection has happened. And that's the point perhaps I'm trying to make, by way of therefore bringing also a connect in terms of how the excluded community in our context, the South Asian context, versus the global context becomes, has a connect and becomes relevant in terms of seeing it. I think recognizing these historical deprivations, the constitutional provision that we have for excluded communities, also makes a mark for us to be able to therefore revisit the provisioning by way of policy making processes, which again, I reiterate, rests on the way data has been collected. Therefore, when we pose the question, who are the excluded groups, the Dalits, the tribal, the ethnic minorities, religious minorities, sexual orientation minorities, differently abled people, how is the data being generated for them? Where is the data, for that matter, for some of these groups, if I may say so? So some of us probably might want to pause here and think about questioning whether discrimination actually exists or not. We've been often told that these are the things of past, they don't exist anymore. But then a couple of days ago, some of us may have, I'm sure, read the newspaper where the CJI, the Chief Justice of India, has made an observation wherein he's referring to the jail manuals, where we still have the derogatory terms being used for certain population groups who are in the prisons. For example, the terms such as scavenging communities, scavengers, may be given the jobs to clean the toilets, etc., as they have been more attuned to be doing those jobs because of belonging to particular communities. So the point, therefore, I'm making is twofold. One is the way we are collecting the data on different vulnerable population groups and the empathy of those who are collecting the population data on such groups. Similarly, I think I would therefore want to also bring in the realm on table in terms of the kind of subjugation, the kind of stigmatization or violence which has been reported in literature through data, NCRB, et cetera, which is largely based on the social identity, vis-a-vis work, vis-a-vis descent. And therefore, I think it becomes very important to get into the nitty-gritty of the social hierarchy, which is so embedded, particularly in context of South Asia. And now, something which perhaps could be pacifying in some way also, that we have similar instances occurring in the global scenario also. And I want to bring in the realm of Nordic countries. With all human development indicators having fairly high, ranks that they have, we have the Samis living in the Nordic regions, which are no different than some of our excluded communities. In fact, largely they are the reindeer herding communities. Because of the hardships. So, if I go by the data that I could lay my hands on, just about 10% of them are now left with doing the reindeer herding. Most of them, the migration, of course, is happening. That's something which is as natural, perhaps, as the very human existence. But what is happening in terms of migration, when they're migrating out of that region, they're being observed in fairly menial kind of occupations, also because of the skills and the capacities which are there. There's also the reverse streams of migration, which is into the regions, which is where perhaps the problem is. The ownerships which are changing in terms of land, the ownership which are changing in terms of the properties, construction of road or construction, the very activity of the construction of road is actually inhibiting their free movement that they would be otherwise having. So some kind of consonance which I'm trying to do perhaps vis-a-vis the nomadic tribes that we have back here. The other context which perhaps I also want to bring in, therefore, and again, the realm is because they are also wandering, the enumeration of these population groups becomes a problem, as perhaps is an issue with the Romani community in the European countries. That's where perhaps the context of identifying these excluded groups, being able to enumerate them in the right way, is one of the beginning points by way of which we can assure what kind of requirements, what are their needs, and that's when the second step of policy making processes begin, programs would begin, and would want to be, meeting the goals of ensuring that we are leaving no one behind. Not that the processes are not on. That certainly is not what I'm trying to imply. I'm simply trying to imply, therefore, the existing programs and policies need to be revisited in the light of the nature through which data collection is happening, wherein perhaps what is needed in terms of the exclusivity of data collection is where perhaps there are the realm is in terms of revisiting, perhaps making amendments for that matter. Because especially if I relate with the Romani community, in Hungary, if I recall my data correctly, about 9% of Hungary's population is Romani community. And one of these school of thoughts proposes that they are the erstwhile migrants from India, Western Indian regions, largely being connected with the nomadic tribes of that part of the country. Therefore, I think because of the nature of the population group itself, it becomes difficult for the very act of enumeration. That's one. The other, when we are trying to talk in terms of settling these populations, which are migratory in nature, the next thing which becomes problematic or becomes an issue is the assimilation of these populations. Most of the time, it has been observed that children from these excluded groups, whether we talk about the global excluded communities or we talk about our own excluded communities, the children may study in the same school as the majority population, but more often than not, we know that the differences become very obvious, and therefore there have been instances wherein the children have been seated separately by way of the need for different kind of training. This is what has been evident in the schools of Hungary, and that's what I was trying to bring in at par with what perhaps we've also experienced when we're talking about the schools wherein different children from different communities, particularly in rural sites, have experienced being seated separately. Anganwadis, for example. Therefore, I think I wish to bring in the element of how these excluded communities can be taken on board by way of their recognition, by way of making sure that what is required for them in terms of being enumerated, only then perhaps the actions towards their betterment, the improvement can happen. One example, again, from the globally excluded community that comes to my mind is of the Burakumins in Japan. As I read the literature and get a sense from the available data, it gives me a sense that amongst all these excluded communities globally, Burakumin seems to have done the best in terms of their improvement of their conditions, in terms of education, in terms of employment, in terms of housing. Therefore, there is possibility to be able to provide for, not that discrimination doesn't exist for Burakumins, but they have been doing better. So the point, therefore, is that if one country can do it, given the resources, given the systems in which those resources are being made use of, I'm sure the other countries could also take a leaf from there. To my mind, this becomes important also because there is a connect in terms of the access to the resources and their utilization by way of how the individuals therefore perceive themselves, especially when the element of stigmatization and marginalization exists. Self-perception has a low, if I may say, low worth, or the self-esteem is comparatively lower as compared to when the perception is of a high worth. Therefore, I think while social identity-based, experiences, if I may say, need to be considered in a way that the erstwhile or historical deprivation that the Burakumins could have been facing, the Romani communities and our own excluded groups on and across various axes, becomes very, very important to be taken on board. And I must point it out here, while we talk about the discrimination vis-a-vis various axes of social identity, gender, to my mind, is the most examined, most studied axis through which we're talking about gender-based exclusion or discrimination. But then the other realms of discrimination that could be experienced by way of being excluded, be it sexual orientation, disability, ethnic identity, religious minority identity, I think those realms are often argued by way of the economic propensities being put in place. The idea being that if economic propensities are taken care of, other social inequalities will be able to, take shape, therefore. But I think it really does not happen that way, because most of the opportunities wherein these realms have to be pegged in exist in urban areas. And we see, I'll shortly come to that point where I'm trying to draw in terms of the differentials that exist by way of the rural and the urban context when it comes to the access to resources. One small point which I also want to make in terms of the data aggregation, which is in our context by way of the politico-administrative background of what I would say as, the data collection process. We all know our census, which began way back in 1871, the first census for that matter. So there is a historical context wherein the data on people has been collected conventionally, the anthropological information on the people by way of which the then rulers, the colonizers, could actually understand the population and rule therefore. The connect, therefore, which I'm trying to draw is, while these data were collected during the census processes, census enumeration, it was also seen that the different groups which existed at that time point, differences have always been there. When the enumerations were happening, the Britishers classified the indigenous or local population into three categories. I'm sure we are all familiar with the superior, the intermediate, and the inferior. The context here is therefore the realms through which the enumeration of those belonging or labeled as inferior was being enumerated. Much of it is relevant from literature, which suggests that they did not even have the information or knowledge to be able to report about themselves. And therefore, I think there is a realm in terms of bringing in the context of the self-image vis-a-vis low esteem, which prohibits in many ways, which hinders in many ways, this realm of being able to return themselves to the enumerator by way of their information. And therefore, this context of denial of access to services perhaps gets connected over there by way of this explanation that I'm trying to therefore put in. This also therefore is evident in terms of how we put across how various indicators of development, one being very, very relevant one, which I would say over and above what I said in terms of employment or education, et cetera, et cetera. One of the more recent data that I was looking at in terms of the multiple dimension poverty index, which I happen to see across the social groups, the administrative social groups, and it informs very clearly while when we are looking at the multidimensional poverty index, out of the population that we have in the country, almost half of them, 55% to be precise, are coming under the category as poor. But among those who are marginalized, who are listed as the scheduled caste, it's 66%. And if I bring in the tribal communities, those who are listed as STs, the share increases to 81%. Therefore, I think it becomes important to take cognizance of this difference, which the multidimensional poverty is kind of throwing it to us, despite the fact that there have been schemes and schemes and schemes over these decades for way of bringing in parity in this gap, in the gap which has existed. And therefore, I think it becomes important to see how do we pitch in these gaps? Should we go by the generic policy frameworks, or should we bring in specific policies for specific groups, therefore to bridge in these policies? Perhaps yes, to my mind. And therefore, I think the disaggregated data by way of these realms across social categories, subcategories, becomes very, very important for us to take on board. The other challenge which I would wish to therefore bring on board is of the heat thresholds. I hope I have some time, or okay. Just a couple of quick points that I wish to bring in over here. Like I said, climate change is something we are all reeling under, we are all talking about, and many a times we are made to believe that these are the larger phenomena wherein individuals perhaps will be not directly impacted. It will be via different large-scale kind of scenarios through which we get impacted. But then we've all seen just in the month of May that each one of us as individuals have been affected by the heat wave that we've all experienced. Therefore, the heat thresholds that each one of us can, as an individual as well as a region, perhaps can take on board in order to refer to the context of creating the vulnerabilities of the individuals by way of bringing in how health services become important, how illnesses, morbidities become relevant vis-a-vis the heat thresholds or heat waves that are important. If I take on board again the sustainable development goals, I'm sure we'll agree to the fact that SDGs have given due cognizance to this problem, And they're very stipulated. If you look at Goal 13, it very clearly tells us that global warming needs to be limited, and it also stipulates to 1.5 degrees centigrade. And it also kind of informs that it is important to adhere to this right away. If we don't do that, there'll be issues which will go beyond the control for that matter. And this is also reiterated by IPCC also. Therefore, to my mind, it really becomes essential to take on cognizance how the various indicators impact and influence this realm of climate change, which is linked to the individuals, to the larger population groups, and therefore the regions in which these populations groups could be located. And therefore data collection perhaps becomes an important link across these realms that become important to deal with. Because the vulnerabilities which are created because of such heat waves, such heat conditions, are impacting, making populations at risk of various kinds, direct as well as indirect, by way of loss of life, which could entail the households, the families, in terms of the livelihoods of the households may be lost. For instance, if I may bring in that realm, other than the individual health impacts that the people could be having. So perhaps the lesson which becomes important to learn here is how do we define the context of extreme heat conditions? Whether it is, different regions have different, what should I say, the thresholds. His thresholds differ for different regions, and that impact, because also the atonement of human bodies for that matter. Therefore, perhaps how do we understand the situation wherein we mark that this is the threshold by way of which we need to prepare ourselves for various kinds of mechanisms through which the conditions can be improved, so as to ensure the pressure on the healthcare services would be viable and enabled for conditions if they arise. Therefore, I think if I take on board some of the examples that we've experienced in the past, during 2003, for example, the European heat wave, when around 15,000 people died in France alone, the temperatures were hovering around 37 degrees centigrade for just about a few years. Whereas if we locate that vis-a-vis ours, just in May, we've had a series of weeks together, to be precise, wherein the temperatures have been in 40 plus, range. Therefore, I think while these things are perhaps still being contextualized, particularly from the point of view of, if I may say, the social determinants, the environmental determinants, and the governance determinants that we can peg in by way of the governance, this perhaps therefore is the right time to be able to lay out a framework wherein we could bring in the realms of the indicators in one way, which will best be able to tell us about the scenarios, help us in being prepared for the conditions wherein the health impacts would be visible and therefore will require to be addressed. Research, in fact, has documented very, very clearly the increase in cardiovascular diseases, respiratory diseases, different causes of mortality, which are being attributed to the heat wave exposures. There is therefore an emerging body of evidence, as is visible from the literature, including the country that is ours, where heat wave deaths have been increasing fairly regularly. And in fact, those are the figures that we have are considered to be underestimated. We really do not know what exactly would be the figures if we have to, really if we get all these data in place. So I think heat waves do become a very, very important peg on which the nature of data will become important. The information, therefore, which will be gathered will also therefore make us relevant in terms of what are these preparedness by way of the existing health conditions, by way of the health infrastructure, by way of the provisioning of the care, therefore becomes very, very important. And I would want to close it here by invoking Dr. Ambedkar's quote, wherein he points out towards how education an accumulation of scientific knowledge becomes important in terms of addressing challenges such as this. And I quote him, "A man's power is dependent upon education, accumulation of scientific knowledge, everything that enables him to be more efficient than savage." And I think this is where it becomes important to be able to sensitive towards the challenges which encounter us, particularly in context of the healthcare services by way of access, by way of affordability, by way of accountability, availability, etc. And therefore, the provisions through which we as human populations, and now, of course, with the context of One Health coming up, we can't really leave behind the environment and the animal health for that matter. And it also therefore connects us with the ESG framework that I'm trying to kind of bring in over here. I think it's important to connect, therefore, the thoughts which some of the elements in the constitutional safeguards have already invoked and are suggesting us to do, and therefore the need to be wary of what is viable and what is not viable by way of ensuring that what is important for the health of the populations becomes accessible, becomes useful, and it shows some kind of positive outcome by way of how we execute the provisional of healthcare services. Thank you so much. Over to you.
Thank you so much, ma'am, for such an informative and comprehensive session of yours. And with this, now I would request Professor Mukul ji to kindly give your kind remarks on this session.
धन्यवाद.
Uh,
The theme of this program has been healthcare policy, governance, and management. And for good governance, management, for good policies, we require data-driven decision. So Professor Acharya has very rightly pointed out that we need to allocate a lot more resources, both human professional resources and money and infrastructure for collecting better and timely data, which can then help us in improving the health status of the community. Let me mention a couple of points. Health in the Indian Constitution is a state subject. There have been some efforts to make it a joint concurrent subject. 15th Finance Commission had suggested that. Has not happened as of now. But there is so little emphasis on states. So, we got large SC, ST communities, others, and so on. But nobody is looking at the state policies, their accountability, their governance. And I think the researchers, instead of overgeneralizing about the country, need to look at the states where the primary responsibility for healthcare lies. particularly for primary healthcare and so on. And even for the central policies, like Ayushman Bharat has more than, I think, 150,000 wellness centers that are part of Ayushman Bharat. For those wellness centers, the state will be very much involved in managing. And so we get this wide variation in outcomes because we underemphasize the state level research and we underemphasize accountability and responsibility of the state governments. And I think this is where we need to go more. My general uh, statement to my public policy students has usually been that the policies made in the name of the poor are poor policies. Make good policies. And good policies for everybody. Don't, I mean, what we call middle class are living at the margin of very small, bad episode of health could take you from being a lower middle class to poor. So don't try to over emphasize certain groups. And even minorities have no real meaning in an analytical sense. Take minorities like Jain, richest community. The minority, where is the richest community in the country, or Sikhs, okay, or Buddhists, or others. So I think we need to now also rethink the vocabulary that we use and the lenses through which we do these type of analysis. Now, India should be extremely proud that we have eliminated extreme poverty. There is no more extreme poverty. Very few countries. And I have data which shows that India's maternal mortality rate for the country as a whole is lower than the global, which is quite an achievement that India has made. So a lot of progress is being made. And I think it's also important that our researchers, our academic community, others also highlight the achievements, positive parts to give confidence to the population to go forward to do better. Always looking at negatives and generalizing is not very helpful for good policies. But the international examples that Professor Acharya gave were very useful and shows very deep scholarship. Thank you very much. And one more point, if I may. I think the Chief Justice of India will be better off trying to reduce the caseload and concentrating the Supreme Court's work on constitutional matters and not on other matters. They hardly do any constitutional work, which is what they are there for. So I think CJI has a lot of introspection and reflections to do before he gives advice to the rest of the country. Sorry, I have a very strong view on its current CJI. Okay.
Yeah, thank you so much, sir, for your kind remarks. And now the floor is open for the questions. The participants can kindly ask their questions by raising their hands or putting the question in the Q&A box. Yes, Ranjan, sir, you can go ahead.
Good evening, everyone, and thank you for giving us this opportunity to be both a participant and also uh, support in the panel discussions. Professor Sanghamitra Acharya of JNU has wonderfully placed the things, and it was really enlightening to many of the issues that have been brought to our notice, some of which were there at the realm of the edge, but they have come to the center stage today. Thank you, Professor Acharya. And of course, Professor Mukul Ashar has already again summed it up very nicely. So, Professor Acharya, I was just wondering, ESG framework you mentioned, does it mean the economic, social, and the governance framework? Would you please
No,
elaborate that once?
no, that doesn't mean
ESG
economic.
framework,
No, it doesn't. It means environmental, social.
environment.
Yes,
Okay.
it doesn't mean. That's why I'm
Environment, social,
talking.
and governance framework.
Yes, that's why.
Very
And
nice.
I mean, much of the literature is talking in terms
Yes.
of the corporate house, but I want to bring
Yes.
it to the board in terms of the academia and policy making. That's the point I'm
Yes.
trying to make here.
Yes. Very nice. And in fact, the international community, particularly the UNICEF, WHO, they have been speaking of the PPE spiral for the last 2.5 decades.
Mhm.
The PPE is focusing on the population, the poverty, and the environment. So more or less they are related. Now the governance has been added to that framework.
Yeah.
And incidentally, we celebrated the World Population Day just 2 days back. That was 11th. And the second point, Madam has mentioned, Professor Acharya has very clearly mentioned was regarding the excluded or marginalized communities. So this was really knowledgeable to us, and it was knowledge to me that 81% are actually coming into the multi-dimensional poverty index. If we include the 50% below poverty threshold, the ST communities up to 66,000 and STs. So overall, 81% is the percentage that you mentioned, if we have got it correctly. So which is a major thing that we in the health sector, we have to think of how to get this corrected and health services delivered. Regarding the global warming that you mentioned, Madam, it was regarding the governmental panel on climate change, and that is also very important that you have been mentioned. And coming to the two issues that I was wanting to additionally mention over here is our population has grown leaps and bounds over the last couple of months, I mean, almost a century now. We are still growing, although the pace of growth has come down to 0.92% probably in the last 2023. But probably that information is based on the NSSO sample surveys that are happening in probably around 6,000 plus urban and rural wards that we have identified. We have not been able to do a complete census since the 2011 census. So, and as has been very clearly mentioned, we need disaggregated data and up-to-date data. In that context, Madam, I would like to mention here health resources for health manpower. This is a very, very important thing without which neither can we deliver our healthcare services to each of these groups, be they be partially excluded or partially marginalized, or even for the mainstream groups. Unfortunately, there has been hardly any creation of post, I would say, at least for the last 30 years, maybe. So we have had various missions, we have had various mechanisms to fill up those existing posts. Of course, only filling up is only a fraction of what is actually required. Because what is required is if we have got, as Professor Ashar mentioned just now, 1.5 lakh plus Ayushman Bharat Mandirs, as we call them now. So we require the manpower to sustain them. And we require quality manpower to lead them. So the leadership is coming basically at the medical officer level and the higher levels in that cadre. Other cadres I am not discounting. Each cadre is very, very important, be it the health worker, be it their supervisors, health assistants, be it the sanitary inspectors. each and every cadre is needed, and each and every manpower requires to be post is to be created, filled up, and they have to be oriented, and then only they can provide the healthcare services. This was one very important issue, which unfortunately, at least in my ministry, I am aware that we have not been able to do what is required. I am at the higher policy level at the Ministry of Health. Earlier, I was the Deputy Director General looking after entire national medical education of the country, as well as I had 4 programs under me. So there we could not fill up those posts. The last year, that is 2023, the pre-election year, there was the mission recruitment drive. We tried to revive many of the abolished or deemed abolished posts. And in that, most of the departments and most of the ministers were quite successful. But still, taking a small example of the 5 institutions that I had here in Kolkata, in this eastern zone of the country, on behalf of Ministry of Health and Family Welfare, I would say that we have been able to fill up about 60% of those which are sanctioned only. So that leaves a gap of 40% still, taking into baseline conditions of, let us say, 50 years back, half a century back. What about the populations that we have accrued over the 50 years? We have not thought of that yet. So I will here like to give a very small example. If we look at the public health specialist of the government of India, this is the Central Health Services cadre. So the total number of sanctioned posts for this public health specialist cadre is around 105 across the country, manning the various airports, the various ports, various important national level programs, various important institutions, let us say my own institution, the Apex All India Institute of Public Health, and similar institutions. The posts are only 105. So an initiative was taken by the Honorable Ministry way back about 5 or 6 years back when I was at the helm of affairs there. Therein, it was decided that a total of about 1100 posts is required, of which it was to be done in 2 phases. The first phase within the 5 years. Am I audible, madam, or I got disconnected?
No, you're audible.
You are audible, sir.
I am audible. I am audible. Thank you. So it was intended to be done in 2 phases. First up to around 500, and in the next phase another 600. But unfortunately, as on date, the numbers are the same, 105. We have added about 40 major ports and airports which require manning by public health specialists, and many programs are being added almost every year. We have added mental health program, we have added, each year we are having at least 2 or 3 additional programs. But where are the people who will be actually giving support and will be leading those? So the creation of the post is a very, very important issue of management and governance, and that any single ministry or department will not be able to do. We have to think of on the national context at the highest level of governance. That is one thing. Second one, the issue that is of One Health is very, very important. I am investigating various incidences of animal epidemics, pandemics, and also human pandemics. And those pandemics which are jumping the species and coming from the animal to the human, and then also from the human to the animal. This is happening very frequently, madam. US is facing major H5N1 pandemics now in the bovine cattle, and of course in the poultry it is there. We are very much concerned about our own scenario. 5 states at least are declared pandemic prone for the poultry, and unfortunately they have jumped species, and I have been given the task of preparing reports and doing international investigations. Now we have got molecular epidemiology and everything to help us, besides our traditional epidemiological methods. So we know where from it has come, where it generated, whether it is a laboratory one or not, everything is there. Now the issue is, in the One Health, we are actually supposed to collaborate between 29 departments. I am happy to share in this platform that the human animal health, they are almost on the verge of forming a healthy cooperation on One Health. And yesterday I was in Ahmedabad in the first valedictory session of we call it Sector Connect program of Field Epidemiology Training program on One Health, in which the Animal Husbandry Department and the Human Health Department of about, I think, 7 or 8 districts at the up to the block level, they are working concerted way, like we have the integrated disease surveillance platform online. Similarly, they have the animal establishment, animal husbandry department has also initiated similar, and they are coordinating very nicely. But we need the environmental ministry, the climate change ministry, the water and sanitation ministry, the wildlife sector to come together. And there are many other departments. So 29 is the number. So we are a long way to go, and this we have to do. Without that, we will not be able to achieve One Health, and we are on the verge of another pandemic. Zika has entered our country, and we are facing H9N1 or H9N2 also, which is a very, very likely to be dangerous pathogen. And similarly, there are hundreds of pathogens lurking around the corner. So one is very important, and climate change is actually also supporting these species jump and mutations, both minor as well as major. So with that, I will not take any further time. I have taken a lot of your time. So thank you very much. And we have to work, and we in the health sector, we are working towards these ends. But the major challenge we are facing is the human resource. That has to be created and has to be supported. Thank you very much.
Professor
Thank you.
Das, you have also provided lot of illumination and education to all of us. So we are very happy that you are taking the time. Sorry, Professor Acharya, I spoke in between.
No, that's absolutely fine, sir. That's absolutely fine. Just wanted half a second from Tanu, if I can just make a couple
Sure,
of
ma'am. Sure, ma'am.
Yeah, one is I am in complete agreement with you, Professor. I shared that health is a state subject, and therefore we can't obliterate the responsibility of health, especially if we have to look at the sub-plans, etc., by way of the subgroups of the population, the SC, STs, etc., etc. But what the problem probably begins when we are starting to talk about the minorities, and you very rightly mentioned the minority has to really be defined. And I'm referring, in fact, the comparison that I was drawing was with the largest minority religious group vis-a-vis the majority religious group. And therefore, I think we really need to look at how the national level figures versus the state level figures will interact with each other to be able to help us in creating the kind of policies that may be important. One all policy, to my mind, may not really become functional, therefore. And as very rightly Dr. Das has pointed out, I think it's very, very important to take cognizance of the vacancies which have been lying vacant for a fairly long time, wherein there is also the realm of, therefore, the plurality of healthcare systems, the plurality of healthcare services that are there, especially when we already have the Ayush ministry in place. The point, therefore, I'm making is, in the light of the vacant positions, in the light of, therefore, the lesser or smaller pool of the manpower that we have at our disposal in health sector, probably it makes sense in terms of incorporating the local traditions of healthcare provisioning, Ayush being right there in front of us as a ministry, and therefore the partnership that we really want to evolve, the convergence between the conventional Western medicine versus the local traditional Ayush systems, the plurality will only work out then. And this plurality, to my mind, is going to help in filling in the gap which is not being filled by way of just addressing the public health through one system of medicine. That's the point I would want to make by way of alluding to what Dr. Das has said. Thank you so much for bringing those points. I really wish we can deliberate on some of those at perhaps a later time point. Over to
Fully
you.
agree,
Yeah.
Professor Acharya. Thank you.
Okay, thank you so much, ma'am, and thank you so much, Ranjan sir, as well. Next, we can take Omkar sir. You can ask your question.
Oh, did I raise my hand, ma'am?
Yes.
Oh, sorry. Okay.
Wo-
Ma'am, this is to Acharya, ma'am. Ma'am, thank you for this session, and it was very nice, where you had, rightly said, the democratizing of the healthcare is very important, where we need to include the all the sections, of the society at the end of the day, right? So you have spoken all the positivities, how it might affect, their healthcare system, their upliftment, etc., and everything. Do you foresee any negative impacts because of special policies creating exclusively to these sections, ma'am?
To this, my answer would be the one all policy in all these years really has not made the difference in terms of the gap that has persistently been there in all these decades. So, which to my mind and to my understanding is kind of suggesting that there is a need to have group specific policies. Maybe one has to experiment with them by way of certain, like we have EAG states. Maybe for policies also, we might want to think about those kind of experimentation. That's my understanding of the persistent gap, and that's my, argument, depending upon, based on rather the literature and data that I am familiar with. I hope.
Understood, ma'am. Understood, but I was coming out, seeing that, the same kind of experiment which we have done in the education system, well way back, right?
Yes.
So though it has been successful in bringing many of the underprivileged into the mainstream, but there has also been a negative side effect of it. I think recently if you could see the paper because of this IAS officer, etc. There are a
Yes.
lot of such incident, which has created negative impacts as well on the society, right?
Yes.
So I think policy, what I believe and I uh, think of on the Mukul sir line is that, rather than policies to a specific group, we should focus on overall human improvement, how we can include the entire population, irrespective of their, gender, caste, religion, minority status, whatever it might be. The policy should address equitable access to every human,
Yeah.
irrespective of the status.
To bring in the equitable access, we need to look at two things. And I draw from the field I work in: social inequalities in health or health inequalities. What is it that you want to peg on? And that's where perhaps you start looking at, of course, it's the human development that we are talking about. But if human development is being accrued to certain groups versus certain other groups, that's where my argument becomes that we need to have subgroup orientation towards this policy generation. And if you are trying to probably make a point that these policies have created differences across communities, have brought in affirmative action, for example, has created drift, etc., etc. One simple understanding that I have to my mind, reservation is available in public sector employment and education. And both public sector employment and education are vested in urban areas, right? I wouldn't see much of the public sector education and employment being, pegged in the rural areas, right? Villages don't have that. But when you look at the outcome of the discrimination based on social identity, it's maximum in rural areas. So to my mind, therefore, there is something beyond what is being nurtured in terms of the affirmative action policies creating the divide. Look at the way we are dealing with our exam systems, therefore. Look at the way there are payment seats available for professional courses. Where is that question coming in from? If this is where I would want to think that these are the policies which divide the population. I have a different take on that. Thank you so much. I hope I've made a response to it. We may disagree, but that's what my point is. Dr. Omkar.
Yeah, ma'am. Well said, ma'am. Thanks a lot. Thanks a lot. Can I ask one last question, ma'am? I mean, just was wondering out of this.
Yes, please,
Yeah.
please. That's
Exactly opposite to my office, we have this UNICEF headquarters in Hyderabad, ma'am, right? So I was interacting with a lady who is working on vaccination in children, basically. Social research on vaccination acceptability in children, right?
Yeah.
So, vaccines are available free of cost at every government center, right?
sure.
Irrespective of whether it is a rural center, urban center, etc., and everything, right? So one interesting thing what she pointed out is that, right, certain minority community, though they have public health system access for this, vaccinations, etc., and everything, so they don't prefer to go and get vaccinated, basically, right? So government is trying hard to, get them onto this stream to help them how to get vaccinated, etc., and all those things. But still, they see there is a lot of gap where people coming in to get vaccinated into the centers. So any data or a reason why this is happening, ma'am, even though when there is an equitable access to vaccinations, for all these people?
Yeah, there are a good number of micro studies which are telling us about this differential. One being, when we say as researchers or vaccinators that these people, and these people could be anybody, XYZ. COVID, we've seen the transgender was not able to access vaccination in the beginning. It was only later on that they could access this thing. Most cases, what happens is there is an inbuilt realm of these are the people who will not come first. So you're assuming, and therefore the dissemination of information becomes the first step, which is blocking that overcoming of what I need to take given in terms of the vaccination as a person from the minority community, for example. So this gap which is there as a healthcare provider or as a health information generator, am I moving to these communities wherein the information is needed to be disseminated as an ASHA worker, as an ANM, or as any grassroots level health worker? Have I been able to do that? Am I free of my own prejudices in terms of disseminating that information? Right. And much of the literature, there are a good number of research which is evident from my own university, the Tata Institute that I'm familiar with, as I've reviewed some of their theses. The contention is that generic policies for large-scale populations function in a particular way. Micro studies give us different kind of information. And that's perhaps where I would probably want to draw your attention to the methodological issues, wherein the quantitative large data sets are giving us the scenario. This is the situation. But why this situation is occurring, why these people are not, like you said, accessing the vaccine, is where the data is not able to tell us anything about. That's where the processes of these situations are important to be examined. And that's what the micro studies tell us. And one of the realms that micro studies bring in is that the access to information itself is hampered, and therefore the stigmas which are generated, the misnomers about vaccination that are generated are not overcome. For example, if I may bring in the realm of ANC care and childbirthing, there are ample evidences by way of literature as well as data, which is suggesting that if I have to take a public sector service, right, in terms of delivering a child, there is a norm each state stipulates, population policy of each state stipulates that I can't go, most of them, beyond the second child, I cannot go and access the public health services. So if I am going to access the public health services for my third child, the trauma which I have to experience becomes a nightmare. And therefore, I refrain from doing that, despite the fact, like you said, equitable services are available for everybody. But if I am producing the third child, perhaps irrespective of my social identity, there will be an issue with that. That's also because the whole idea of policy, population growth has been instilled in a particular way in the larger frame of minds vis-a-vis the people, vis-a-vis the policymakers, vis-a-vis the system itself. So these are some of the issues which I don't think can be seen in the realm of right or wrong, but they need to be seen in the realm of the policy processes, the process through which we initiate this dialogue and come to some kind of conclusive programs, mechanisms which will bring about the change. That's where perhaps I would want to begin my argument.
Thanks a lot. Yeah. Yes.
Can I add to what Professor Acharya has mentioned? If the chair permits me, I can make
Yes.
a couple of observations and which I would like to share. Coming to the first issue of regarding what we call in technical terms is vaccine hesitancy.
Yeah.
So that is why people are not accepting a service which is being provided. Here I would like to point you out that if there is hesitancy, it has a lot to do with advocacy and IC. That is information, education and communication. Or now we call it as SBCC. So for this particular aspect, there was a cadre entirely at the block level, which was known as the block extension educator.
Mm-hmm.
This was created when the community development block system was adopted by our nation. We had a post of block extension educators. So they were both in the agriculture side and the block development side, and we in the health also had got this post, block extension educator. Over the past 3 or 4 decades, now gradually these posts have already lapsed and there is no one person who is looking after this. So who is supposed to do the education and the SBCT work? So it is the health worker, actually the ANM or the health worker female mainly, including the health worker male. Again, the health worker males are also almost an extinct identity. So the work has now percolated to the ASHA, who is not so fully paid, neither fully experienced nor fully educated to provide this particular very important aspect of education. Without the education, there will always remain some hesitancy, and particularly there is hesitancy. For example, there is lack of impotency or a lot of things. I mean, the onset of impotency, which has already been percolated. So what we need to do is, if at all we need each of the subgroups to take up the vaccination, our IEC has to be strengthened. Unfortunately, that is not happening, because what is the average time that our doctor or the vaccinator is able to devote to each individual beneficiary? When a patient is coming to the clinics, let us say, hardly we are able to give 2 minutes, 3 minutes is the average time that we give. We simply write a prescription, the patient speaks 2 or 3, before he or she has been able to complete their chief complaints, the prescription is almost ready. I am sorry to say, but this is the truth. Now, same is the situation when we speak of the, let us say, vaccination sessions. The vaccination sessions are supposed to be done in coordination with various other workers also. We have got a method which is known as Village Health and Sanitation Committee, which is a multi-cadre committee. They are supposed to do the joint thing along with the ICDS, along with the ICDS helper, along with our health worker, our ASHAs, and of course it has to be done under the able leadership of some senior leader. What is happening is, practically everything is percolated only to the last person in the line, which is the ASHA, who is not a full-time worker, and she is paid incentive-based, work-based incentives. So under the circumstances, our health education system is very, very weak. Until and unless we strengthen this system, we cannot expect the vaccination level to increase. And it is related with all other aspects, so we will not delve further into it. The second point that Professor Acharya mentioned, that one size cannot fit all, is very, very true and apt. And most importantly, it is very true for a country as large and as diverse as India, where we need disaggregated data, of course. And I am very happy to share in this platform that Professor Acharya's institution has taken a lead in that particular direction recently. Just yesterday only I got this information. I'm just passing on this information. No comments I am making. The Central University Entrance Test, it is a centralized, and JNU has probably taken a decision that they will hold their own test. So this is one small example of governance and management, that one size may not fit all. So we may require different policies and mechanisms at the various district levels, at the different state levels, because what is fitting West Bengal may not be fitting other states. Let us say Northern India, UP, or it may be different in Punjab, it will be different in Tamil Nadu, it will be different in Kerala, like that. So that we have to understand and accept, and we should not be attributing particular communities or particular societies the way that it has become now almost traditional, and has become a mainstream rather than an exception. So I think that way we will be doing more service to the further deliverance of the healthcare system and reducing the inequities. Thank you so much. Back to Professor Acharya and Professor Ashar.
Thank you so much. I don't think I have anything to add in over there. I've made my point. I'm sure these are the nuances which we need to work through by way of adhering to what SDG calls for, leaving no one behind. So that's my closing point for instance. So over to you, Tanu.
Okay, thank you so much, ma'am. And again, thank you so much, Ranjan sir. Next, Swati ma'am, would you like to unmute yourself and ask the question?
Yeah, good evening to all, and thank you,
Good
IMPRI,
evening, ma'am.
for giving us such a insightful session with Professor Acharya and Professor Ashar. And Professor Das also brought the ground realities, which is making this session more informative. My question, it's not a question, but a observation. I'm a visiting faculty at NMIS and at TISs, and also work with the ground level schools and colleges and healthcare workers on various issues. And what I have observed in that the national the overall national thing is to give a lot of privilege to the private sector, and we can see that 80% is private sector. But there are no policies to regulate this private sector. That is A.
Yes.
C is that the social determinants are not only impacting directly to the health, but also the commercial determinants of health are also impacting directly the non-communicable diseases. If you see the history, 2 decades or 3 decades back, we never had such NCDs because our lifestyle was very Indianized. Okay. But once the processed food started, coming in the markets, okay, and it became easily accessible, the whole NCD thing has gone up. And we are really becoming the capital of NCDs in all the stages. So my question to Professor Acharya and Professor Ashar is, how do we control these factors which are actually the main factors of the diseases or the unhealthy situations of the people? Because there are no policies for these things, and they are nowhere seen also in the health policy. And I think if we keep on working on only the health issues related to the disease and not looking at the lifestyle and the social factors and the commercial factors and the economic factors, we are not going to head anywhere. Yeah. That's my precise question to both of you. Thank you.
Tanu, can I come in? Thank you so much, Dr. Rane, for bringing this on board. I'm sure we've had these conversations in many other platforms too. So thanks so much for bringing in. You're absolutely right. We can't restrict ourselves to only the social determinants of health, given the context in which we are providing healthcare services. As you said, commercial determinants of health become very, very important. Privatization of healthcare has taken a very different direction, which is also therefore impacting the access to health services. We are one of the highest countries which has highest out-of-pocket expenditure. Now, in that scenario, it's not really possible to not talk about the commercial determinants of health. Much of the medication is being governed by the pharmaceutical industry. And therefore, I think you're absolutely right in saying that commercial determinants become very important, particularly given the quantum, levels of population that we have vis-a-vis poverty line, given the inequalities that we are reeling under in terms of, any data that you would see. The inequality lab has released a data, I think about a couple of months, so April is when they had. So in fact, I would want to add in what you said in terms of the commercial determinants of health, even the financial determinants for that matter. And I would want to bring in the awareness, the IEG realm of even the literacy, financial literacy for that matter. And that's where I'm connecting the realm of what the very theme of the day is talking about in terms of what is it that if I may say, the responsibility of the healthcare system provisioning cadre has, by way of therefore the medical ethics, by way of over medicalization, by way of therefore malpractices, if I may use the term. And we all know how the I'm trying to get the right word, the connects that we see in terms of the pharmaceutical industries and the private sector healthcare providers. And therefore, the role of, if I can bring in the medical representatives per se, by way of promoting one drug over the other, promoting the drugs of one industry versus the other pharmaceutical company for that matter. So I'm completely on board. We have to move beyond the social determinants of health, or rather incorporate the commercial determinants of health as much if we really want to make sure that inequalities are taken care of by way of the groups and the subgroups that we have around us. And all the more when the newer diseases over and above the NCDs that you've already referred, if we inflate it to the One Health idea, One Health concept, which is a reality, how do we deal with the zoonotic diseases alongside when we have NCDs, we're becoming the capital of good number of NCDs by now. Diabetics, we are already there. Cardiovascular, we are reaching there. So absolutely on board with you, Dr. Rane. Thanks for bringing that up.
Yeah, my
Thank you
second,
so much.
Tanu, if I
Can I add, there are a couple of points very important to be added here to what Professor Acharya has mentioned. And of course, I would
Ranjit sir,
want, yes, yes.
sir,
Am I audible?
I would be grateful if you could add your points in a minute or so, because we have
Perfectly fine.
one more.
Perfectly fine.
Thank you,
Perfectly
sir.
fine.
Thank you.
Okay.
yeah. So Tanu, can I?
Yes,
Yeah.
ma'am.
So, in respect to what Professor Ranjan said about the vacancies, and also if you see the IC material, what we are saying, we are always thinking about ASHAs, but nobody is thinking about the nurses. And I feel nurses play a very important role because they are with the patient 24/7. I completely see the invisibility of the nursing cadre in the healthcare system or in the ministry. It is almost more than 75 years, but we don't have a director of nursing in the Ministry of Health.
Yes.
There is one nursing advisor and she doesn't have any uh, any powers.
Yes, absolutely.
So that is the major structural issue at the ministry level. Same you can see at the state level. In the state level, we see completely invisibility of the nursing cadre. We continuously harp on the MBBS doctors or the allopathy doctors. I feel they need to be more with the patients than sitting on the other side of the table, because they would be the ones who are needed at the clinical levels. Public health specialists, I feel if we create a cadre for nurses as public health specialists, they would be the right ones, because you can see in places like Canada, United States, NHS of UK, we have major roles played by the nurses.
Yes.
And I feel somewhere, because of that, we are missing the game in the Indian healthcare scenarios, because they are the major resources which are there, but they are not utilized properly. The second thing about them is that the nurse practitioners, wherever the doctors are not available, we have to put the nurse practitioners, and they can take care with the help of telemedicine of the tribal areas, and they would be more than happy to do that work. So this is my input from the work what we are doing with the nurses right now. Thank you.
Yeah, thank you so much, Swati ma'am, and thank you so much, Ranjan sir. Next, Sanghamitra ma'am, thank you so much for joining us today, and we are really grateful for such an informative and comprehensive session of yours. And thank you so much, ma'am.
Having
Next,
headed the nursing division also, I just wanted 2 points to make. Only two, maybe 30 seconds I will require.
sure,
First
sir,
point
go
is that
ahead.
we have got participation in the form of community health officers at the block level and at the sub-central level. Sorry, not at the block, at the sub-central level. So we have got many of the states have already started taking nurses as the community health officers. Number 1 point. Second point, the bill is also passed regarding the nursing new council is coming up, and we have got what she mentioned, what Dr. Rane mentioned, that yes, we are having a course also which is already approved, the clinical nursing assistant or something she mentioned. So that course is already, it will roll out very soon. In fact, I have already given a proposal to start an All India Institute of Nursing Specialties, just like we have AIMS. And at my very institute, at All India Institute of Hygiene and Public Health. So we are working on it, and shortly we will do it. Thank you.
Very good. That's a
Very
good
encouraging.
initiative. That's very good initiative, sir.
Thank you. So that's a very excellent way to go ahead, I feel. And
If I could get 30 more seconds so that I could clarify the two other points which were raised by Dr. Rane's issue only. She mentioned about NCDs and the commercial determinants of health. Just 30 seconds if I am permitted.
Sure, sir, go ahead.
Thank you very much. Regarding the clinical commercial determinants of health, it is very, very important that there are two different acts which are there. One is the Clinical Establishment Act. There is a central act, and many of the states have also enacted, but there are only 14 states which have their acts in place. And the problem is, even in those states, the implementation of the act is very, very weak. So we need to encourage other states to have their own acts so that the quality can be ensured. Number one. So this will take care of both private as well as government institutions. Regarding the second aspect is that we have got an organization which is known as CSFE, Central Drug Standards Control Organization, under the Directorate General of Health Services, Government of India. They are the agencies which are supposed to control the drugs. I was just watching a movie today itself, a couple of hours back, which is known as Pill. Kindly have a look at that Pill movie. That tells us how our system works. That is a true real story. And as per that movie, 25 to 30% of the drugs are either fake or substandard. We have to address that issue. That is a very, very important issue. The last part, I come to the NCDs. NCDs is not just because of the couple of things that we are thinking. It is our lifestyle. We are working at 6 p.m. We will be working up to 8:30. And we at the higher levels as well as the grassroots levels at many places, we are doing exactly the opposite of what is required by our Ayurvedic system of medicine or any system, we would say. Am I audible? Did I get disconnected?
No, sir, you're
Yes,
audible.
you are
Acha,
audible.
I am audible. Okay, thank you so much. So if we need to not to be the NCD capital, there are 4 things we need to follow, 4 or 5 things. I will not elaborate here. I have earlier spoken about it once. There are some communities which are known as blue zone communities. Just look into the internet. So it is a style of taking in non-processed foods, leisurely style of work, the hurry-worry that we are having currently, the type of processed food that we are having, and everything combined is giving us those NCDs. There is no single simple answer to not to be the capital of NCDs. So just look into that aspect. Blue zone communities, that will give us what is to be done, what is not to be done if we want to prevent the NCD. Thank you very much.
Thank you.
Okay, thank you so much, Ranjan sir, for joining us and commenting. Thank you so much, Sanghamitra ma'am. Now moving ahead, I would like to invite Professor Mukul Asharji, former professor, Lee Kuan Yew School of Public Policy, National University of Singapore, visiting distinguished professor IMPRI for his concluding remarks for this program. Over to you, sir.
Dhanyavad. We have 2 tasks to perform in the remaining 30 minutes or 35 minutes that
Yes,
are
sir.
left. One is that we need to get a feedback from
Right.
the participants, because the program is always to be judged once the program is over and all the parts have been something that the participants have been exposed to. So I have created the slides, and I think I have sent them as well, which you can share with them, which sort of summarizes what I see as the mega messages from the program. All this time we have been speaking as resource persons, different ones. So I think it's just fair, and it will be very helpful as well if the participants today first indicate the kind of 1 or 2 big messages. Now, what is a big or mega message? It is that after taking this program, as you're thinking about healthcare policy, governance, management in any area changed compared to your priors? And is there anything that has impacted this program on you that would be helpful in your future work? And I think that, in any program, if we can get 1 or 2 things like that, the program becomes worthwhile. In my slides, I have tried to indicate some of those that I think would be useful, but better that we hear from the participants.
Okay. So the floor is open for the feedback session. The participants can kindly unmute yourself and give the feedback for the program.
So the slides that Professor Usher was mentioning, will they be visible? I just checked my email; it is not there yet.
No,
Or will we get
Mukul sir,
them through
why don't
email,
you?
or will it be
Mukul
shared on screen? Okay.
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 Mukul sir, why don't you just for once run through the
Okay,
slide
let
very
me
briefly?
run
Yeah.
through the. I think you can get out of those. I will do a sharing on the screen. Can you get out of this?
Yes.
What you have?
Yes.
Okay. We got. Is that okay now?
Yes, you are
So-
visible, sir. The screen is shared.
I mentioned that health is a state subject, but researchers don't think to hold any state accountable, responsible policies, what is going on. Some states are doing well in some areas, others are doing well in other areas. Why and what? And that research is lacking. So 15 Finance Commission wanted it as a conference. So we need much greater awareness. Now we haven't talked about money, fiscal part, which is very important. In 2022-23, combined center and state government receipts were 29% of GDP and disbursements about the same. So we need to be very careful that 30% of GDP is spent through our governments. What are we getting? How do we get more value for money? And that is a question the researchers must be asking, not just at the macro level, but at the micro level. Ministry of Health Welfare budget was 990 billion, 22-23. And of course, all the state governments have their own budgets. States spend more than the center in the aggregate. Okay. But the states, as I said, don't receive scrutiny. So these are the big numbers on the fiscal side. Now, there are also many of the schemes we are doing, PMJ, Ujwala, Jan Aushadhi. By the way, somebody was talking about commercial aspects of drugs, but one of the most important innovation initiatives by this government, for particularly the lower middle class and the middle class, are the Pradhan Mantri Jan Aushadhi Kendra. And you can get all kinds of medicine at a much cheaper price than a chemist would sell it. So they have been able to use the scale, buying scale, and others to try to reduce medicine prices, which reduces your expenditure, which is same as increasing income. So many people tell me I'd rather have cancer in India than in the United States because here I can afford it. Now, many of these programs have what we call as the fiscal contingent liabilities, which have not been researched and which need to be researched. Contingent liabilities must be recorded if the contingency is deemed probable and expected loss is likely to occur. So they are conditional on the occurrence of a specific outcome. And that is something that all the health schemes we need to think of, and the state schemes too, because the states have their own schemes. Many states have got schemes specific to women, which they give. And there are huge contingent liabilities that need to be estimated. Okay. I won't go now much more on this because it's a very technical area. The Ayushman Bharat is reported to be expanded to all individuals over 70 years, and the limit will be raised to 10 lakhs. So we have to see how it will be financed. Okay? And what are the factors affecting fiscal costs? Moderate aging, healthcare inflation, usually higher than overall inflation. That's true globally. Why? Because healthcare is a more labor intensive related service. And as the time passes, though the productivity in these areas is more difficult to increase than in goods, producing cars or steel and so on. But you have to pay them the societal wage. So the per unit cost go up, inflation is high. So that will drive fiscal cost and contingent liabilities. There's also one of the things that was talked about is the low level of physical activity level. So one of the larger points I want to make is that people also have duties and responsibilities. Not everything is government, and not everything is government's fault. Not everything is system's fault. Not everything is commercial business guys' fault. There are also individual responsibilities and duties that you need to perform. Many are not. And as uh, Dr. Ranjan said, they are not living a lifestyle that needs to be lived. You can minimize some of it. You know, for 30 years, I took lunch cooked by my wife to the office. I didn't even know the canteen food, so that I could eat in the office. And of course, the Mumbai Dabbawala are the biggest example. But notice that our physical inactivity is rising in India and at all levels. And that is something we need to correct. Lifestyle, dietary habits, and shift from curative to preventive. That is something that we need to take seriously. How many people still mock yoga and pranayam and meditation and all that? Those are preventive care, which have got tremendous benefits, civilization, and it's our civilization. Our maternal mortality rate has declined from 556 in 1990 to 97 in 2018. Maternal mortality. The world is 223. The world, we were way above world, and we are now way below world. That's a tremendous increase. So after all the limitations and all the things about the healthcare system, in some areas we have made a tremendous achievement. And the researchers have a responsibility to point out our achievements as well as our failures. Don't keep on having negatives and keep on reducing morale of the people. Now, here is another one. Is our quality of life improving? We are talking about SC, ST, OBC, and so on. How much fruits they are eating? Proportion of the poorest who hold fresh fruits from 29% to 70+%. Most of them are able to have fruit. Does that show exclusion? Does they show this? And we need to have more and more in terms of the education and diet. How many of you would know that? How many researchers are pointing this out? And this is also government data from the NSS 68th round. So don't pick data that are all negative and remove, and don't use the data that also show some positivity. We are including the medical infrastructure and so on. And poverty dips to 8.5%. Okay, says NCAER paper. So we have reduced poverty substantially. Okay, and the headcount ratio as poor. Now, this is the multidimensional poverty that's also been reduced quite substantially. So don't always think of glass as half empty. Sometimes think of it as half full too. We are including our infrastructure and the this is the capex, because capex is very, very important. Now, one thing we need to understand when we talk about commercial and all this is that Europe and others have used the medical baselines for their commercial advantage hugely. So Europe is changing baseline for certain things now. And what we need to do is to create our own baseline. That's where Professor Ranjan and his organizations, his type, will try to create disease benchmark which are suited to Indian patients and not take the global benchmark. After all the things that have happened, things like WHO, UN, others have little credibility, okay, in terms of what they do. US FDA, out of 650 US FDA approved drug manufacturing plants, 25% plants are outside the US in India. And we need to leverage it for our for this good record to improve our health. Also, connectivity. This is a larger thing. Connectivity will allow you to access health better and faster. So here is the electrification of railways around the world. Global average is 47% electrification of railways. India is 90%. Point out the positives. This improves our healthcare. So health system doesn't mean narrow health aspect. It also means the connectivity and so. And these are the state-wise inflation rates. I won't go into this, but notice that we are thinking of satellite-based toll collection system. So you won't have even the FASTag that you have to go through. You just go through. And if you reduce the time of travel, if you reduce the physical distance, time distance, and you see that you are going to see significant opportunities to improve healthcare, and the insurance are going to be better off with less accidents, others, because we have very high incidence of motor accidents. And so one way to deal with it is to go to this satellite space. I'll just India's medical tourism that we had talked about, and we have to use AI to medical data to combat misdiagnosis and so on. So we have got some very large mega messages that we have had is to think positively, okay? Look at improvements, look at efficiencies, how to improve, look at improvements and get encouraged. We have made tremendous fertility rate. Who would have thought that our total fertility rate will be below replacement rate? How did that come about? Can't come just from there. There's a social norm change. There are economic pressures. In Mumbai, how can you have more than 2 kids? you can't afford it. There's no housing that is large enough, others, and so on. So a lot of different factors, but our fertility rate has declined. So population kind of pressure that we all live with is not a problem anymore. Indeed, we have to worry about the old age and do more geriatric medicine, specialization, others, the Parkinson disease, others, so on, that we'll have to focus more on. Last point. India is no longer a rural country. If you define urban right, we are urban and para-urban. We are going to be a majority urban country by 2030 to 2035. Don't think rural urban. It has no meaning. Talk about rural urban. Talk about that we will be a majority urban and we need to provide. President Kalam long time ago wrote or had an idea called Pura, providing urban amenities in rural areas. That is Pura. So yes, good policies, accessibility, affordability, provide all of those, but don't use terms which have no analytically sound meaning for policy purposes like urban. We will be majority urban and we got to think in urban terms. The 16th Finance Commission that is going on right now will have lot of very fundamental things that they will recommend about urban management and urban finance. Okay, thank you. So now can we go on? Thank you
Yeah,
for
thank
the
you so much, sir.
opportunity.
Thank you so much, sir, for your concluding remarks. The floor is now open for feedback, questions, and comments. If any of the participants would like to make, they can raise their hands. Yes, sir. Ranjan, sir, you can go ahead.
Again, it is focusing on the same NCDs. We cannot rely only on yoga for reducing our NCDs. Physical activity is very, very important. It has already been mentioned out here.
Yes, agree.
Many across the government, they have got specified that these much activity, physical activity is essential, 5 to 6 days a week, and that is minimum around 30. So we have never communicated this to our national population. Our health system has miserably failed on this. So this communication and many other things, I would, that would be my final comment. Thank you.
Okay, thank you, sir.
How do we provide the feedback that was asked from us? Is it some
Sorry,
form? How do we provide the feedback? Is it oral or is it some format that
Yes,
has been designed?
we will be
sir,
sharing the feedback form, but
Okay.
orally, if you'd
Okay.
like to share anything regarding the topic or the program.
Surely. If I am permitted, other speakers, they should also get chance.
Right.
Maybe
Omkar ji.
I think other people must get a chance, then I will also share. Thank you.
Okay. Omkar ji, Swati ji.
Uh, yes, I think it was an excellent way of bringing the major issues which are never discussed in the mainstream academics or in the practice. And I think Professor Asher did a great thing by bringing so many lenses to health sector. Being a professor in health sector, I have hardly seen anybody touching those important nuances. And economy, I never thought I could see so positively otherwise in health sector. So I think that such deliberations are needed. And also the audiences were such a rich audience with so much of knowledge, which really brought added advantage for all the practitioners to understand healthcare from different lenses, because healthcare is no more a medical field or a clinical field. It's a social, economical, now financial, and we are seeing also commercial field. So I think such deliberations with interdisciplinary team, if brought on, will really help the health sector management and governance, as the topic itself it is, and in the Indianized way, because we are just copying the West, which is not going to help India. So I feel that such deliberations are needed by the government and by the private sector both. And instead of working in silos, let's all come together and work together towards health and well-being of the nation. That's my thing. And I think this IMPRI platform has really brought that silo. It has broken down those silos and brought all of us together. So thank you, IMPRI, and thank you all the faculties and the audiences, which gave so much of insights to me as in at an individual level. Thank you so much.
Dr.
thank you so
Rane,
much.
Dr. Rane,
Yes.
health is also now political.
It was always political, I think.
Right. So we need to, that's what makes it so complex.
Yes.
Okay,
Yes.
that's what we have been emphasizing throughout the program. That
Yes.
it is complex. Don't overgeneralize. Don't make assertions, and so on. Go into good policies, good governance, good management, and so on. But understand these larger nuances and factors that are at play.
Yes, and
So-
looking at the population now, which we have, the adolescent population is major, and we don't have any policies for them.
true.
Health
is needed, especially mental health is needed so much for them, but there is no access for them to, go and check. And unfortunately, they are going to Google uncle and Google aunties, and that is not helping them. Now there is Insta aunties and uncles there who are not really giving them the actual information. So I feel that now we have to rope in the schools, the colleges, the parents, the workforces, the workplaces. Those are the areas now we have to target if you really want to bring healthcare.
Let me ask the participants. Do you think the length of the program was right, or should it be a bit longer?
It was perfectly right, sir. I think that
Okay,
4
fine.
days and 2.5 hours roughly each day.
Yeah.
Sometimes we have exceeded. That was, I think, optimal.
Okay, fine. Thank you.
Thank you.
Anybody else?
Yeah, thank you so much, Swati ma'am. And even we are grateful to have you here with us. Next, we can take Omkar sir. You can go ahead with the feedback.
Yeah, yeah. Thanks everyone, IMPRI team as well, because the program has been, wonderful, since you have tapped experts from different areas, with different perspectives and different expertise. So we are able to learn a lot of things, through their experiences, since they are working in the different departments. So that is the first point, which I wanted to make. Second point is that, yeah, the course was, very well articulated and, structured and delivered. I feel that, maybe few more classes would have been great, because you would have got more interactive with expertise, and get, overall, what you call, more knowledge, in terms of what is exactly happening in various sectors, in the field, basically, right? And third point is that, India has always been evolving, country, basically. Rather than developing, I would call it as evolving country, because it has a unique population with unique experiences. And I feel fortunate, the healthcare system has been one of the best, what I see, because I can walk into any hospital in a Western country, but I can't get a quick answer to my problems. But here, within a minutes, I can walk into any public or private hospital, consult the doctors, and I get my answers. And even operations, if I need to perform, it is just a matter of time to schedule and everything, right? So such is the beauty of the healthcare system in India. But as you all said, definitely it's a long way to improvement. So I think as we go ahead, with the good policies and guidance from experts like you, I think definitely, we would evolve and, meet the expectations of the people. So these are the 3 points, which I would like to make here. Thank you.
Thank you so much, Omkar sir, for your kind feedback. Next, Manorama ma'am, you can go ahead. Ma'am, we cannot hear you.
Please
Okay,
unmute
we can.
yourself, Dr. Manorama.
Okay, Ranjan sir, you can go ahead first.
Okay, thank you for this opportunity. This was a wonderfully designed, wonderfully organized, and a wonderfully delivered summer immersion training program online. So, which really helped us to look into lot of micros as well as macros of the health sector management and governance. It really opened our eyes. So, as top level managers of the government of India, so it will help us in taking healthcare delivery into a new realm. That was one thing. And as has been told to us by various experts under the leadership of Professor Usher, today's Dr. Professor Sanghamitra Acharya from JNU, Professor Bakshi, who mentioned about the MVT, that is Medical Value Tourism, Dr. Urvashi Prasad from agency I'm forgetting, Professor Pradeep Kumar Panda of the Ayush, specialist of Ayush, and Dr. V. Ramakrishnan, Dr. Parashuram Patel. Everyone has given us a lot of insights into how our healthcare needs to be taken further for management and governance. And the last point has been very aptly mentioned by Professor Usher a little while ago, that health requires a lot of politics, and actually health should be the centerpiece of politics. That is where we should move, because after all, we cannot achieve anything without health. If we remember our malaria control program, at that time our country was progressing very nicely on the production, both on the agricultural front as well as the industrial front. There we lost because we could not control our malaria. Similarly, now we are having many other challenges. Malaria we have not been able to control yet. Close to control, but certainly not eliminated or eradicated. And we have about a half a, about 50 more problems now, new problems which have to be addressed. NCDs are one of them. Our One Health is looking after a lot of mutations and lot of things. So we need to work together, have total new thinking. It will be total new way of thinking. And that new thought has been provided through this platform. Thank you very much. And particularly your anchoring, Tanu, which is wonderful. And thank you very much, the entire team of experts, and my colleague participants. Everyone has given us a lot of insight and knowledge also. Thank you very much.
Yeah, thank you so much, Ranjan sir. And even we are very grateful to have you here. And we got to know a lot from you as well. So please do join us in our further programs. Next, Lakshmi ji, would you like to say anything or give your feedback? Neena ji, Lakshmi ji. Okay. Professor Pradeep Panda ji, would you like to give your feedback? We would be very grateful if you could do so.
Hello, everyone.
Hello, sir.
Actually, yeah, as all the participants have mentioned, and I have been attending all the Saturdays, although I was having lecture on IUS only one Saturday. So throughout the program, I attended all Saturday just to know how it is going, as you can see. I also get the feeling that it was very nicely organized. The resource persons were very good. And on the top of all, the participants are very interactive. They are asking lots of genuine and real questions, hard questions, and good to know about it. And Professor Asher has been a strong moderator with immense knowledge, practical knowledge, a lot of evidence-based, data-instigated insights. So that is very nice to know. And I enjoyed very much. I think it was a great workshop. All the participants, all the resource persons, and the organizers, all of them have done a good job. Thank you very much.
Thank you so much, sir, for your kind feedback. Manorama ma'am is back. Ma'am, would you like to continue? Okay, ma'am is not audible. Dr. Ritika Sahuji, would you like to say something? Even Amanda ji. Okay. Okay. Okay, let's move ahead.
So we can have, Prasasha, would you like to make any final words?
No, first I would like to thank everybody. Because, usually what happens is that in these kind of programs, the balance of trade is usually in my favor. I get to impart little bit to the participants, but in return, I learn a lot. And for a person of my age to be interacting actively with the younger generation people, thinking and learning what they are thinking, what their issues are, it also keeps me healthy. So for the health program, that I have had a double benefit. I think we have had some very intensive type of discussions, and we should try to continue to make more cohorts or host more cohorts on healthcare policy, governance, and management. Because policy, governance, management in healthcare is something that needs emphasis, re-emphasis all the time. And the more people we can get this exposed to, the better off we'll be. So thank you, IMPRI, for asking me to be involved in this program. Thank you, Tanu, for excellently moderating it. And as usual, Arjun, for your vision and energy. I really marvel as to how much public goods you and IMPRI are producing in a relatively short time.
Yeah,
Pranam.
thank you. Okay, thank you so much, sir, and thank you so much, ma'am. Let's move ahead. So, as we come to the end of day 4 of Health Sector Management and Governance, an Indian Perspective, an online national summer school program, a 1-month immersive online certificate training course, I, Tanu Paliwal, researcher at IMPRI, Impact and Policy Research Institute, would like to propose the formal vote of thanks on behalf of IMPRI, Center for the Study of Finance and Economics, IMPRI Web Policy Learning, New Delhi. We are grateful to our experts for day 4, Professor Sanghamitra S. Acharya ji and Mukul Asher ji, for taking out your valuable time and giving an opportunity to the participants to learn from this online certificate course. We thank all of our participants who have actively participated in today's celebration. Readings for the session have been shared in your email, and a video of the session will also be shared with you for learning. We are grateful if you're watching us on YouTube or listening to us on our podcasts or reading our publications. We hope you continue to join in future to our IMPRI Web Policy Talk and Web Policy Learning. Wishing you all a very good evening. Thank you.
Good evening and thank you.
Thank you.
Thank you, ma'am. Thank you, sir.
Thank you,
Thank
everyone.
you.
Bye bye. Yeah.